Hello, my name is Stephanie Duncan, and the following presentation will be over Chapter 16, Resolving Ethical Dilemmas for Nurse 916, Nurse Practitioner Roles in Primary Care. There's overlap between ethics and the law. Ethics is a branch of philosophy that discusses and analyzes what is good for an individual and for society. Rarely are the answers black and white. An individual may think one solution to an ethical dilemma is correct, but another individual may decide otherwise. There is no overall referee on this earth. There are, however, guiding principles. Laws set rules about what is right or wrong, permitted or illegal. Laws can be made by state legislatures, the United States Congress, regulatory agencies, or courts. Laws may attempt to be black and white about what is right and wrong, but they rarely succeed. With a legal dilemma, a law may state what is prohibited, but the line between right and wrong often is subject to gray areas and conflicting interpretations, just like ethics. Arguments can be made about what a law means, and arguments can be made that a law does or doesn't apply to a specific situation. In nursing and in medicine, the guiding general rule of ethics is do no harm. This principle is attributed to the Greek physician Hippocrates, who died in 370 BC. His statement was, make a habit of two things, to help or at least do no harm. The clinician who employs Hippocrates' guidance every time something is ordered or advice is given will have a sound basis for ethical practice. Academics in nursing and medical ethics use these terms: beneficence, justice, fidelity, non-maleficence, and respect for autonomy. Beneficence is benefits others by preventing harm, removing harmful conditions, or affirmatively acting to benefit another or others, often going beyond what is required by law. Justice is treating others equitably, distribute benefits and burdens fairly. Fidelity is loyalty, fairness, truthfulness, advocacy, and dedication in relationships, includes promise-keeping, truth-telling, and fulfilling commitments. Non-maleficence is the obligation not to inflict harm, balancing unavoidable harm with benefits of good achieved. Respect for autonomy, acknowledging a person's right to make choices, to hold views, and to take actions based on personal values. The reader who wants to explore biomedical ethics in depth is invited to visit the website of one of the academic centers for biomedical ethics. For a practical view of the ethical dilemmas inherent in nursing, view the Code of Ethics for Nurses from the American Nurses Association. This document covers relationships with patients, but also relationships with coworkers. It's a 65-page document with 9 provisions. There are a multitude of ethical issues that come up in a nurse practitioner's daily practice. These include whether or not to disclose to a patient that the NP or someone else at the practice made a mistake regarding the patient care, whether the availability or lack of reimbursement should determine whether a service is provided, whether participation in a research study is the best thing for a patient, whether a promise to a patient or family member not to disclose information to a family member or patient best serves the individual, whether and when curative treatments should be stopped, when and how to terminate a relationship with a patient, whether or not to accept a gift or meal from a vendor or pharmaceutical representative, whether to discuss the deficiencies of a patient's insurance coverage with a patient, whether and how to tell a patient you are moving to another practice, whether and how to inform a patient that you believe the surgeon he or she has chosen is not competent. The text outlines several ethical scenarios that will be discussed further. The first is the case of Roberto Landon. He was a nurse that was terminated from his job at a nursing facility shortly after he reported patient safety problem to a supervisor. A patient had died during the night who he was familiar with taking care of. The nurse had given the patient twice the amount of insulin and had fallen throughout the night, but the nurse never checked a blood sugar and never checked several times after the patient had fallen. Landon was fired for writing a report regarding safety for this nurse. During the trial, Landon's attorney used the American Nurses Association Code of Ethics to show that Landon was bound by professional ethics to report his finding about the quality of care issue. This case shows the interaction between law and ethics. There is no law that a nurse must check on a patient at any specified interval, and no law that another nurse may or may not report another nurse to a supervisor. Nurses have an ethical obligation to do something when they feel patients are receiving inadequate care. Scenario 1 is a scenario of a patient having a seizure publicly in a grocery store. The nurse practitioner worries, should he or she act in the public setting without a physician collaboration? Situation 2 is the nurse practitioner gets a letter from a pharmaceutical company inviting you to participate in a roundtable discussion hosted by the company. There will be nurse practitioner attendees that all provide women's health care. The topic will include hypercholesterolemia in older women. The company has a prescription product for reducing cholesterol. The letter offers you $500 plus a gourmet dinner. The writer wants to send you a consulting contract. Scenario 3 discusses the nurse practitioner arranging an annual conference. The nurse practitioner heard from past conference chairs that some pharmaceutical manufacturers will engage in any and all of the following sponsorships activity: purchase booth space in the exhibit hall, provide unrestricted grants for general conference overhead in return for a listing as sponsor on the program, fund specific speakers including their speaking fee, travel expenses, slides, and handouts, purchase books as gifts for attendees, fund the travel expenses of some high-volume prescribers. Scenario 4 discusses a patient wants to quit smoking. Their health plan will pay for Wellbutrin, which is prescribed for depression, but not Zyban, the same drug marketed for smoking cessation. The nurse practitioner wonders whether it is insurance fraud to save the patient money by treating smoking cessation with a prescription for Wellbutrin, given that the medication and the dosing is the same as Zyban. There are forces that drive nurse practitioners to act in the public setting. These forces that drive clinician care include fear of a lawsuit for malpractice if they neglect to treat an illness, fear of a charge of patient abandonment if they do not give care, the need for compensation, and clinicians' own values, which include their sense of ethical responsibility. With a situation similar to Scenario 1, a nurse practitioner who ignores the person having a seizure is doing nothing illegal. There is no legal requirement for a healthcare provider to pay attention to patients. For a successful malpractice lawsuit, 4 elements have to be satisfied. First, there must be a duty of care owed to the patient by the clinician. Second, the clinician has to have breached the standard of care. Third, there must be an injury to the patient. Fourth, the patient's injury must be causally related to the clinician's breach of the standard of care. In the case of the woman seizing in the grocery store, a clinician cannot be charged with patient abandonment if the clinician never becomes engaged in the woman's care. Patient abandonment is defined slightly different from state to state. It is not patient abandonment, therefore, to refuse to accept an assignment or a patient-nurse relationship. Therefore, a nurse who walks by a person in distress on the street cannot be accused of patient abandonment. In a roadside assistance situation, reimbursement is not an issue. There is no system under which a clinician can submit a bill for care. The reimbursement settings of care are office, hospital, nursing home, patient home, and domiciliary facility. There are no procedure codes for the setting sidewalk and grocery store. Lastly, the clinician faced with the decision to ignore or become involved with an individual in distress will weigh his or her assessment of rights and wrongs and attempt to come to a decision. Some considerations might be as follows. Are there other people already helping the individual? Are my skills any more helpful than what is already being done for the individual? What exactly can I do for the patient? Do I have the legal authority to diagnose and treat the situation? Will I feel that I did not meet my own expectations of myself if I passed by without offering help? If I were the patient and the NP walked by and saw me, would I want the NP to offer help? NPs make situation-by-situation decisions about whether to become involved with the clinical care during off hours. There is no legal mandate to offer services. Moving on to Scenario 2, accepting gifts or payment from a pharmaceutical company. When a pharmaceutical company offers a clinician substantial remuneration for minimal work, it raises suspicion that the company is looking to create a situation where a clinician feels obligated to prescribe the company's medication. The questions that separate a kickback from a business arrangement for services are as follows. Is the clinician in a position to generate healthcare business for the manufacturer directly or indirectly? Is any one purpose of the remuneration to induce or reward the referral or recommendations of businesses payable in whole or in part by a federal healthcare program? Does the arrangement have the potential to interfere with or skew clinical decision-making? Does the arrangement or practice have the potential to increase costs to the federal healthcare program's beneficiaries or enrollees? Does the arrangement or practice have the potential to increase the risk of overutilization or inappropriate utilization? Does the arrangement or practice raise patient safety or quality of care concerns? The pharmaceuticals industry's own Code on Interactions with Healthcare Professionals provides the following guidance. It is appropriate for consultants who provide services to be offered reasonable compensation for those services and to be offered reimbursement for reasonable travel, lodging, and meal expenses incurred as part of providing those services. Compensation and reimbursement that would be inappropriate in other contexts can be acceptable for bona fide consultants in connection with their consulting. Token consulting or adversary arrangements should not be used to justify compensating healthcare professionals for their time or travel, lodging, and other out-of-pocket expenses. The following factors support the existence of a bona fide consulting arrangement. A written contract specifies the nature of the services to be provided and the basis for payment of those services. A legitimate need for the services has been clearly identified in advance of requesting the services and entering into arrangements with the prospective consultants. The criteria for selecting consultants are directly related to the identified purpose and the persons responsible for selecting the consultants, and have expertise necessary to evaluate whether the particular healthcare professionals meet these criteria. The number of healthcare professionals retained is not greater than the number reasonably necessary to achieve the identified purpose. The retaining company maintains records concerning and makes appropriate use of the services provided by consultants. The venue and circumstances of any meeting with consultants are conducive to the consulting services. The Office of the Inspector General, Federal Registrar Notice on the Compliance Program Guidance for Pharmaceutical Manufacturers, issued in 2003, states the following. In general, fair market value payments to small numbers of physicians for bona fide consulting or advisory services are unlikely to raise any significant concern. Compensating physicians as consultants when they are expected to attend meetings or conferences primarily in passive capacity is suspect. The U.S. Department of Health and Human Services, through the Department of Office of the Inspector General, outlines several compliance guides. These are a series of voluntary compliance guidance documents that include hospitals, nursing homes, third-party builders, and DME suppliers. Moving on to Scenario 3, accepting financial support from a pharmaceutical company. PharmaCode prohibits the provision of meals to clinicians except when accompanied by an educational session in the clinician's office or hospital or at a speaker event such as a conference, and it also prohibits the distribution of non-educational items such as pens. The organization decided that even a small token can influence a clinician. The PharmaCode has these caveats about pharmaceutical company involvement in third-party educational or professional meetings. This includes financial support should be given to the conference's sponsor rather than to an individual participant. Responsibility for and control over the selection of content, faculty, educational methods, materials, and venue should remain with the conference organizers. Pharmaceutical companies should not provide direct support for conference meals, though a conference director may decide to use general support money to pay for meals. Pharmaceutical companies may not support the expenses of participants. The Pharmaceutical Research and Manufacturers of America also has a code regarding relationships with healthcare professionals. This includes informing healthcare professionals about the benefits and risks to help advance appropriate patient use, provide scientific and educational information, support medical research and education, and to obtain feedback and advice. As a safe harbor for anti-kickback, the OIG recommends the following. What degree of influence does the physician have directly or indirectly on the generation of business for the manufacturer? Does the remuneration take into account directly or indirectly the volume or value of business generated? Is the remuneration more than trivial in value? Do fees for services exceed the fair market value of any legitimate, reasonable, and necessary services rendered by the physicians to the manufacturer? Does the remuneration have the potential to affect costs to any of the federal healthcare programs or their beneficiaries, or to lead to overutilization or inappropriate utilization? Would acceptance of the remuneration diminish or appear to diminish the objectivity of professional judgment? Are there patient safety or quality of care concerns? If the remuneration relates to the dissemination of information, is the information complete, accurate, and not misleading? A safe harbor from violation of the anti-kickback is described with the following 7 standards. The agency agreement is set out in writing and signed by the parties. The agency agreement covers all of the services the agent provides to the principal for the terms of the agreement and specifies the services to be provided by the agent. If the agency agreement is intended to provide for the services of the agent on a periodic, sporadic, or part-time basis, rather on a full-time basis for the term of the agreement specifies exactly the schedule of such intervals, their precise length, and the exact charge for such intervals. The term of the agreement is for not less than 1 year. The aggregate compensation paid to the agent over the term of the agreement is set in advance, is consistent with fair market values in arm's length transactions, and is not determined in a manner that takes into account the volume of any referrals or business otherwise generated between the parties for which payment may be made in whole or in part under Medicare, Medicaid, or other federal healthcare programs. The services performed under the agreement do not involve the counseling or promotion of a business arrangement or other activity that violates any state or federal law. The aggregate services contracted for do not exceed those which are reasonably necessary to accomplish the commercially reasonable business purpose of the services. As described in Situation 3, an NP arranging the annual state conference may arrange for pharmaceutical manufacturers to do the following: purchase booth space in the exhibit hall at which they will distribute information, provide unrestricted grants for general conference overhead in return for a listing as sponsor on the program, fund specific speakers including speaking fees, travel expenses, slides, and handouts as long as the information the speakers provide is educational and consistent with patient safety. It may be ethical to try to save the patient money, but it is illegal or fraudulent to diagnose depression in a patient whose mood is normal so that the patient can get a prescription covered by insurance. Here is what the U.S. Code says about fraud. Whoever knowingly and willfully executes or attempts to execute a scheme or artifice to defraud any healthcare benefit program or to obtain by means of false or fraudulent pretenses, representations, or promises any of the money or property owned by or under the custody or control of any healthcare benefit program in connection with the delivery of or payment for healthcare benefits, items, or services shall be fined under this title or imprisoned not more than 10 years or both. If the violation results in serious bodily injury, such person shall be fined under this title or imprisoned not more than 20 years or both. And if the violation results in death, such person shall be fined under this title, or imprisoned for any terms of years or for life, or both. Is it fraud if you diagnose smoking and prescribe Wellbutrin? Probably not, because you're not deceiving anyone. However, the insurer is likely to deny payment for Wellbutrin. Is it fraud if you diagnose depression and omit any reference to smoking? Yes. Is it fraud if you diagnose depression and smoking and prescribe Wellbutrin? Probably not. However, ask yourself if you can make this argument that the patient is depressed and a smoker, or that he is using nicotine to self-medicate for depression, or he may be depressed about his smoking. In addition, before taking that route, consider, unless a patient is truly depressed, you may not want to enter that diagnosis unless the patient truly is. In the future, the patient may want to authorize his medical records to a prospective employer. If that happens, you don't want the patient to be surprised or upset that he has a documented history of depression. Furthermore, are you willing to follow up, perform, and document the depression scales, and give the standard of care for depression, that is, to treat for 12 months? A clinician may have the best intentions to relieve the patient's problem and save patient money, but the risk probably outweighs the benefit in these situations. In general, NPs might approach a situation with ethical considerations in the following manner. Gather information. Is this a legal rather than ethical question? Is there a law governing this situation? Consider laws governing scope of practice, kickbacks, patient privacy and confidentiality, billing Medicare, Medicaid, and commercial insurers, Good Samaritan laws, and end-of-life issues such as the decision not to resuscitate. Who is benefiting from this situation and how? Who is being hurt or could be hurt from this situation? Do I have a gut feeling about what is the right or wrong course of action in this situation? Am I being swayed by what is beneficial to me or my group? What would other ethical practitioners do? Does my state board of nursing have any guidance regarding these situations on its website? Does my malpractice insurance cover me in this situation? Structure a plan. Identify the course of action you'd like to take. Identify alternative approaches. Identify the pros and cons of the preferred course of action, as well as the alternative approaches. If it is a patient care matter, present the issue to the patient, if it is appropriate. Tell the patient that you would like him or her to direct you in this situation. If it is a business matter, consult with your partners, committee members, employer, and/or employees. If there is a code of conduct from a governmental agency, a professional society, or your own institution that applies, then follow the dictates of that code. Make a decision, and prepare for yourself an argument that supports your decision. Carry out your plan. If you decide later that you made the wrong decision, learn from your mistakes. In regards to resolving ethical dilemmas, there are pros and cons, especially regarding ethical situations versus laws. Both ethic considerations and laws have black, white, and gray areas. While the black and white areas can be nice, sometimes the gray areas can be hard for the practitioner to determine what is right and wrong. It ultimately, in ethical dilemmas, is the nurse practitioner's decision to decide what is right and wrong based on their preference. Ethical dilemmas have impacts on the nurse practitioner's role. There's ethical obligations to report inadequate care. Situation by situation decisions need to be made, and the nurse practitioner must weigh the risk versus the benefits. Below are the references used to create this presentation. I look forward to the conversation regarding ethical dilemmas in the healthcare setting.